my name is Bogdan Bulumac. I'm the general manager of Biogenis. Biogenis is the Romanian cord blood bank, part of the FamiCord group. Welcome everybody to our enlightening conversation with the pioneer researcher in cord blood therapy for autism spectrum disorders. Our guest, Dr. Felician Stancioiu, is a distinguished physician and researcher at the forefront of the using own cord blood in the treatment of autism spectrum disorder. Dr. Stancioiu's work explores therapeutical intervention, offering hope and possibilities for the children affected by autism. So once again, Felician, thank you very much for accepting our invitation and share with us your vast experience.
First of all, thank you, Bogdan and Ola, for this opportunity. I really appreciate it. And also the team from FamiCord and Biogenis for having me here. And I have to say that for the first time, I prepared my answers for the 9 topics that we'll discuss today. And I did this because I want to overcome emotions. We lose some spontaneity, but we gain the preciseness and the information that we discuss today. I hope is very useful for many people.
Can you provide an overview of the current understanding of autism spectrum disorder and its various manifestations?
The very first children were diagnosed with autistic disorder in 1943 by Dr. Leo Kanner, who published his finding in the journal The Nervous Child, and a description of a series of 11 children with similar behavior, and also coined the term autistic. These kids had various developmental deficits in the areas of verbalization, understanding, focus, initiative, social interaction, and some also show lack of eye contact, avoidant or withdrawn behavior, irritability, hyperactivity, inadequate verbalization, aggressivity. So there are myriad manifestations of this developmental disorder, and I can say that so far I have not seen 2 kids with deficits of the same type of amplitude. At the same time, there are also common traits which must be present in a child so that ASD can be diagnosed, and this disorder has 2 main defining features: the presence of repetitive, restrictive behavior, also called stereotypical behavior, and reduced or absent social interactions with own family or other children. On the verbalization side, the deficits may range from using peculiar words or unusual syntax or repeating certain words to shouting nonsense words to being nonverbal. Some kids are very agitated and some are aggressive by shouting, jumping, pinching, biting, hitting, and some go as far as self-harming. And by contrast, other kids are very quiet and impassible when addressed. Many ASD kids are anxious, and the interaction with the medical staff is difficult because of prior unpleasant experiences, such as drawing blood or being disciplined. And it is very important to note that even though their analytical capacity or understanding is not well developed, they pick up very easily emotional clues from their environment, especially from parents, and they tend to mirror their parents' moods. Essentially, all their functional cues are based on perceived emotions, so if parents are stressed out or anxious, then the kid does not make sense of the content of communication, and is not swayed even by nice words and becomes very agitated and in some cases inconsolable. So it is important for the parents to play a role and be a very positive emotional presence when kids are around. On the causes of ASD, we know many things, but there is also missing information. We know that a majority of ASD kids, around 3 out of 4 kids, have detectable levels of inflammation, such as increased erythrocyte sedimentation rate, CRP, tumor necrosis factor alpha, certain pro-inflammatory interleukins such as interleukin-1 beta, interleukin-6, 8, increased alpha-2 globulins. A few ASD kids, around 10%, are showing small patches of demyelination in different brain areas, and this is likely related to the inflammation present in the brain. And I have seen cases with migrating pattern, meaning solved demyelination in the initial area and the occurrence of new demyelination on subsequent MRI. On the functional side, some kids have abnormal levels of ferritin, which is linked to ferroptosis, meaning cellular death occurring as the oxidative degradation of cell membranes is initially countered by increased iron oxidation, after which further deterioration and apoptosis becomes inevitable. We have also seen abnormal levels of homocysteine, sodium, growth hormone, bilirubin, and we have recently published these findings and the respective recommendations. We also know that in ASD brain there are dysfunctional neurons and networks, especially in the prefrontal cortex, a brain area associated with personality and behavior, and also in areas of the brain associated with formation and processing of emotions, amygdala, nucleus accumbens, which seem to be less connected and controlled by the cortex, and so the emotional responses are inappropriate and difficult to stop or modulate. This seems to be related to the fact that compared to other types of cells in the body, the brain has a higher occurrence or percentage of cells with genetic modifications, which range from small, such as single nucleotide polymorphisms or SNPs, in which only one nucleotide out of a few hundred or a few thousands is modified. Then there are medium alterations such as inversions, deletions, repetitions, copy number variations, in which entire blocks of genes are modified. And also there are severe alterations in which entire chromosomes are missing or duplicated. Those genetic modifications which originate from the troubled division of a single cell may result in a group of cells in a certain area of the brain with deficient function. And it was shown that about 800 genes are linked to the ASD pathogenesis. Besides the clear singular modifications in key genes, which can be seen on WES or WGS reports, whole exome or whole genome sequencing, as pathogenic variants, usually these genes, clearly pathogenic genes, are involved in migrations of neurons in certain areas and the formation of synapses. Besides this, there are also SNPs, which are not as clearly linked to ASD, classified as unknown variants of important unknown, VUS, variants of unknown significance. So they are not clearly linked to ASD, but this happens when considered individually. However, when they are chained, meaning there are simultaneous other SNPs in the same functional direction, this can result in impaired neuronal or glial function and dysfunctional synapse formation. And for example, we have the mitochondrial cytochromes, the CYPs, which are type-specific for various areas of the brain. Some kids have more than one gene modified, and this makes therapy very difficult. In some kids, there are vulnerable genes which give some functional equilibrium until an external factor, such as inflammation, modifies this functioning, or the neurons or the support cells in the brain, the glia and the astrocytes, and indirectly this affects the function of neurons and reflect in various symptoms, including seizures, especially ones associated with fever. With 800 possible genes which can be affected, there are many possible modifications in the neuronal function, and this may explain the different manifestations and the degree of impairment of the child with ASD. Finally, there are two other important modifications seen in the autistic brain: the increased number of synapses in certain areas of the brain and this was seen both on functional MRI and in post-mortem studies in about 60% of the ASD children as an estimate, and increased neuronal apoptosis, meaning neuronal death, in certain brain areas related to cortical control of emotions, which was also seen on post-mortem studies. But recently we have shown that the vast majority of ASD kids have increased levels of neuron-specific enolase. Another key molecule in these two instances is the nuclear factor kappa beta, which plays essential roles in both inflammation and also in the formation of new synapses, which are needed with memory and learning. And it seems that when nuclear factor kappa beta is hyperactivated by inflammation, excess synapses are formed, but these synapses are not functional, and this is followed by caspase activation and neuronal death.
Let me ask you, how common and when these kids are diagnosed, do they present some specific symptoms which should be visible for the parents?
We start by saying that the current studies estimate that 1 to 2% of live births in the developed world have this associated pathology, the ASD, meaning that about 1 in 50 newborn children in the European Union and the United States are affected with ASD. And currently there are an estimated 5 million children and adults in the European Union living with ASD. Boys with ASD outnumber girls 4 to 1, so there are more boys than girls. It was shown that the presence of certain genes linked to the X chromosome have an influence, but not the Fragile X syndrome, which is part of the differential diagnosis of ASD. Another observation is that given the link of ASD with inflammation, it is likely that children born during pandemic years may have a higher incidence of ASD, but this needs to be confirmed by an epidemiological study. Parents are usually the first to notice that something is unusual with their child. The child does not talk, does not look when called by name, does not hug, nor initiate contact with mother. This happens usually at around the age of 1 year until 2 years. This is when usually parents notice something is not right. Sometimes the kids are even tested for hearing loss because of the lack of reaction to words or being called by name. And in some cases, parents notice repetitive behavior, such as the child's fascination with repetitive movement, such as watching the washing machine spinning for hours on end, playing alone, avoiding certain foods or food colors or food textures. There is also the special rare occurrence at the age of 1 year or 1 year and a half. Rare means that it happens in about 1 in 10 kids with ASD, and in these cases the parents noted a big regress in the child's performance after administration of polyvalent vaccines at 12 or 18 months, or after a very severe bout of infectious disease which require hospital stay. Again, this is a very rare occurrence, but I have encountered it. There are also situations when the diagnosis of ASD is made at age 3 or later, mostly because of poor access to healthcare or the wait-and-see attitude, and in rare cases due to certain difficulties faced by parents, including marital strife or not fully agreeing with the diagnosis, which can place a certain stigma on the child. In very few cases, the poor social interaction and repetitive behavior is noted by the medical staff, who refer the child to neuropsychiatrist or psychologist for further evaluation. It is also important to know that besides ASD, there are other developmental disorders, for example, inborn error of metabolism, the Fragile X syndrome, and the presence of one developmental deficit, even extreme, is not enough to make the ASD diagnosis. There are exceptional cases where severe verbalization deficits are present, especially in boys, The example being Albert Einstein and Lucian Blaga, who had only started speaking at the age of 4, but these kids lacked stereotypical behavior and social dysfunction, so they cannot be classified as ASD or Asperger. In some cases, the child can show exceptional ability on a certain area, such as performing mathematical calculations, having photographic memory, and until recently, this type of ASD with an exceptional skill added was named Asperger's syndrome. However, this is not in use anymore.
Okay, so we have to tell to our future audience that who is Lucian Blaga? Because,
Yes.
okay, us as Romanians, we know who is.
It's an exceptional personality in Romanian culture, also featured on the 200 lei currency. He was the only philosopher who made the complete philosophical system. He wrote 2 very nice novels, a lot of theater plays which were translated and played in many European countries, and perhaps the most interesting poetry after Mihai Eminescu. So it's a
Great.
giant of Romanian culture.
Thank you very much. Can you tell us, please, which are the treatment options available in this moment?
Sure. The main treatment option today is psychotherapy, and it has shown good results, especially for children with minor to moderate impairment. Psychotherapy consists of 10 to 40 hours a week for each child. To this sometimes is added speech therapy, meaning additional hours for the child training. And it makes a very busy schedule for both the child and the family. And it also has a significant economical impact on both the child's family and the healthcare system, so that a recent study estimated in the United States the care cost of autistic spectrum disorders will exceed the costs with diabetes, which are huge, before the year of 2030. Besides this main therapeutic option, the psychotherapy, parents do with variable results other therapies such as neurofeedback, chelation therapy, hyperbaric oxygen, and even dolphin therapy. It happens. There are supplements which help in some cases, and this works best when blood, urine, and stool tests can show modifications in the metabolism, in the immune function, and or intestinal flora. Those tests have allowed us to help improve the child's development in some special situation with specific supplements, and in some cases there were more noticeable improvements with supplements than after cord blood administration. We'll come back to this later.
Okay.
A special mention is the Nemechek protocol, which addresses primarily the inflammation produced by different bacteria and fungi in the intestine, and I have seen kids who made clear progress after this treatment. There are numerous supplements which can help kids with ASD, and we have detailed the blood test and the respective supplements used by us in the CORDUS study in a recent article, which also presents the results of the study. The key here is to do the testing and prescribe accordingly to the modifications. No, don't go first empirically in giving the supplements.
Okay.
We also have to say that parents of ASD kids have quite a few options of clinics where stem cells can be administered in the European Union. Some of them use bone marrow stem cells, such as Vienna clinic, and some use cord blood or cord tissue, and there are centers in Eindhoven, Bratislava, and Belgrade. And there are also such clinics in Turkey, Asia, Panama. But these clinics have not published the results yet, and their activity is not focused on research, and was not organized in the form of a clinical study, even though there is a big need for data.
Okay, great. Hearing what you said, can we say that the autism spectrum disorders persist through uh, the entire life?
Yeah, it's an important question, and I get asked this very frequently. The answer to this is not a categorical yes or no, and is not the one-size-fits-all type, and needs to be more detailed and nuanced. There are studies showing that about 1/3 of children with ASD make good progress after psychotherapy, and they no longer qualify for the ASD diagnosis. However, in the majority of these kids, there are some lingering issues throughout the life of the child and the future adult, and this can be exemplified by the first children diagnosed with ASD. And this happened in 1943, as we said earlier. It was a boy diagnosed by Dr. Kenner. Name appeared last year in an obituary that I came across. Name was Donald Triplett, and he was described shortly as oddly distant, with no apparent interest in his parents or anyone else who tried to make conversation to him. He was obsessed with spinning round objects and had an unusual way of speaking. He was substituting you for I, confusing appellatives, and repeating words like business and chrysanthemum. I hope I pronounced it correctly.
Okay.
He also showed a savant-like brilliance, naming notes as they were played on the piano, so perfect pitch, and performing mental calculations with ease, so that when a visitor asked 87 times 23, he didn't hesitate before answering right away and correctly 2001. Donald Triplett lived his whole life and died at the age of 89 in a small town in Mississippi. He graduated from college, worked as a bank teller, and traveled the world, and all this with support from his family and hometown. So it is possible that some of the deficits are completely reversed. However, even in cases of moderate dysfunction, the child can live relatively independently with some support from family and community and have a meaningful and happy life. Other than this anecdotal evidence, we have two recent cohort clinical studies which gives us a good idea of how kids with ASD will develop. The first study, authored by Elias and Lord, published in 2022, followed a cohort of 155 children from their diagnosis, around 2 years of age, until adulthood, and found that 19%, 19, lost the diagnosis before age 18, and even more as adults, so that half of the ASD kids lost the ASD diagnosis as adults. This result is in line with previous studies which estimate that around 20% of kids with ASD will lose their diagnosis as adults. This is somehow tricky because they lose the main features, stereotypical behavior and avoidant, deficient social interaction, but still there are some issues, as we have seen with Mr. Triplett. A more recent study published in October 2023 last year by Harstad observed 213 kids diagnosed with ASD between the ages of 1 and 3 and found out that a much higher proportion, respectively 37%, lost the ASD diagnosis before the age of 7, and 92% of these kids received ABA therapy, applied behavioral therapy, and girls have better evolution than boys, meaning that 61% lost the ASD diagnosis versus 61% of the girls and 32% of the boys. However, there were important differences between this cohort and those in previous studies, primarily in that participants had higher cognitive and language scores. So they were better prepared, let's say. They were in milder forms of ASD. And also there were no Hispanics, and those kids tended to receive better education and treatment, and it was linked to the parents' social status. In the same direction, a previous study by Professor Fine in 2013 showed that children with severe ASD and very low developmental scores at enrollment, so initial scores showed very severe ASD, were very unlikely to make progress with therapy.
Can you share with us what led you to explore the potential of the cord blood in the treatment of ASD?
This is perhaps the clearest answer so far and perhaps the shortest. Working with the ASD kids was a totally unexpected direction for me. So in 2018, I was working with mesenchymal stem cells for stroke, neurovegetative state, spastic paralysis, and using adipose-derived mesenchymal stem cells, which were harvested from the patient's autologous or close relatives. And there were some positive results, which I published the following year. However, the best therapeutic improvement was observed when I used the stem cells from fresh cord blood and adipose-derived mesenchymal stem cells, and this gave me some thinking. Soon afterwards, the parents of a child with ASD insisted that we do in Bucharest the administration of cord blood, which they heard was helping children with ASD. And sincerely, at the time, I thought it made no sense.
Okay.
And tried to persuade the parents to do other treatments and delayed the intervention for many months. But at some point I read the literature, and especially the study from Duke University from 2017, and I decided to go for this treatment knowing that autologous cord blood carries little risk, and we administered the cord blood to a very agitated and uncooperative child who fought the intensive care doctor to her best abilities. And 1 month afterward, we had the first follow-up visit. And I was very surprised to see a very changed child, a very different child from previous visit. She was making eye contact, smiling, responding to requests from parents, speaking when prompted, totally something else. And this convinced me to continue on this path. However, the next child was over 8 years old and over 35 kilos of body weight, and also had a much more severe form of autism. It was non-verbal, and unfortunately this child did not show any improvements after cord blood administration. And these first 2 children initiated a pattern which will hold for the following years of the entire study, which is younger children getting good and sometimes exceptional results, children younger than 7 years old, and older children having a much lower rate of improvement after treatment.
Can you explain for us how cord blood therapy works in the context of complex, in the end, ASD treatments?
Cord blood has different types of stem cells in different proportions, and currently we determine only the total nucleated cells, or TNCs, and the hematopoietic stem cells, or HSCs, which have the cellular surface marker CD34. And this because they are used primarily in hematology oncology for reconstitution of bone marrow after high doses of chemotherapy. These immature HSC, hematopoietic stem cells, had no contact with antigens encountered by the growing child and may generate healthier white cells. So these cord blood cells were not primed for inflammation by various antigens, and in some cases the white cells primed by these various antigens, especially when are given simultaneously or the inflammation is very severe, can also produce autoantibodies, meaning antibodies which target own cells. And this is the case of autoimmune diseases. And in our study, we had detected in 2 children antibodies against neuronal antigens, SOX1 and amphiphysin. So this is one aspect. Cord blood also contains mesenchymal stem cells besides the hematopoietic ones, and these have 2 important beneficial characteristics for ASD. They can differentiate in many cell types, including neurons, and have important immunomodulatory properties, therefore reducing inflammation by decreasing the pro-inflammatory functions of white cells. And on this direction, we have tested the cord blood on the content and viability of hematopoietic stem cells and mesenchymal stem cells by determining the presence of surface markers, CD45, CD34, CD133, and CD271, as well as 7-AAD. So we went beyond the standard of care. And importantly, there is a previous study done by Dr. Cucci in 2010, which showed that the proportion of CD133 positive, which is a marker for hematopoietic stem cells, and the CD271, which is the marker for mesenchymal stem cells. So the proportion between HSCs and MSCs determines the site of migration and implantation of mesenchymal stem cells. So that the 8:1 proportion favors lung implantation and 1:1 proportion favors brain implantation.
Okay.
So this is an important detail. Some cord blood grafts contain stem cells with embryonic markers, NANOG and SOX and OCT, which are even more capable of division and differentiation into many cell types and are able to replace the neurons destroyed in ASD. This testing is not currently done, and we are trying in the future to expand our capabilities to include this aspect. Finally, the cryogenation of cord blood involves the presence of a special substance, the dimethyl sulfoxide or DMSO.
DMSO, okay.
And this has anti-inflammatory properties, also protective effects on the neurons, and promotes preferential differentiations of mesenchymal stem cells into neurons, multiple advantages. So the administration of cord blood harvested at birth and cryopreserved in DMSO, as opposed to fresh cord blood, has this added benefit.
Okay.
And in summary, decreasing inflammation, the paracrine neurotrophic actions, and providing neuronal precursors are three important therapeutic directions addressed by cord blood in ASD.
Can you tell us, please, which were the promising findings that or outcomes that you observed in your research regarding the use of the cord blood in the ASD cases, which led you in order to continue the same research with a new clinical trial?
Thank you. The CORDUS study was conducted between 2019 and the summer of last year, 2023, and perhaps the most immediate and consequential finding was the fact that most children with ASD have increased neuronal destruction, and we were the first one to be able to evidentiate the increased levels of the neuron-specific enolase in the blood of ASD kids, which is pretty I would say not unexpected, but it's a good evidence for the therapeutic direction that we want to go and develop further. The increased NSC was a pervasive feature, and we have observed it in the vast majority of the kids tested with ASD, meaning over 95%. And NSE can act as a biomarker for diagnosing ASD in conjunction with specific neuronal inflammation markers such as GFAP, glial fibrillary acidic protein, and also can act as a dynamic marker which shows the efficacy of the therapeutic intervention in ASD. Another important consequence of this finding is that increased neuronal destruction present in ASD should be not only diminished but also compensated by replacing the lost neurons with new ones. On this front, we have two possible pathways. One is stimulation of the child's own neurogenesis, meaning the formation of new neurons from the stem cells already present in the child's brain. And the other pathway is administering stem cells, which should generate new neurons and also improve the conditions in the brain which lead to neuronal destruction, so alleviate this aspect, which is due mostly to inflammatory mechanisms. Also, in the CORDUS study, we have acted on both pathways, meaning both supporting the child's native neurogenesis via supplements and also by administering stem cells from cord blood, which provided new cells to replace damaged neurons and improve the functioning of existing ones. I think this is an important factor which has led to improving the percentage of kids who benefited from treatment in our study from about 50% in previous studies in which cord blood was administered to about 75% of success rate which we have seen in the CORDUS study. And some of the kids achieved big leaps in progress, as recorded by the parents on video and also as evaluated by the child's psychotherapist.
Okay, great. Can you tell us, please, if there are any specific challenges or maybe limitation associated with utilizing the cord blood in ASD treatment based on your experience?
I can say a few things on this. Firstly, during the pandemic, which you all want to forget, we had logistical difficulties in bringing cord blood in Bucharest, especially from states outside of European Union. And we advise parents to choose stem cell banks which have a laboratory and storage facility in the country where they live to avoid unexpected delays or restrictions in utilization of cord blood. Of course, the use of autologous cord blood is limited to children who have it harvested at birth. And I met parents who were considering using the cord blood from a future newborn, so planning for a new child. This should not be the first reason for having a sibling. Considering the genetic component of ASD, there is a risk estimated at 18% when there is a child with ASD that another child in the family will also have ASD. And also, due to the fact that I met families with one affected child and the rest of kids with typical siblings, but also families with multiple affected siblings. And also family with 3 children and all 3 with ASD, and this is not a good thing to happen. More important questions are related to the use of own cord blood for ASD, which is a non-life-threatening disease, versus keeping the cord blood for possible later use in oncological transplant. So if the kid will unfortunately develop such a problem. And this is a decision each family has to make, and we can only point to the fact that there is a low chance for a child to need transplantation, about 1 in 10,000. And also for the past decade, new sources of stem cells have been identified for oncology, and these sources were used preferentially before cord blood. For example, haplo-identical transplant, and more recently a medicinal product, the expanded standardized cord blood. Also, there is the logical question of how useful can be own cord blood, autologous cord blood, when the child has a likely or clearly identified genetic problem, which were shown to be linked to ASD. And the answer we give on this one is on a case-by-case basis. If the genetic defect is severe, such as a chromosomal duplication, aneuploidy, then we prefer not to administer autologous cord blood. And also, when there are moderate to severe repetitions, deletions or inversions involving tens or hundreds of genes, we prefer not to recommend autologous cord blood administration. However, when point mutations are identified, the SNPs, the single nucleotide polymorphism, we are not against autologous administration. We base this on the fact that the genetic analysis performed, either the whole genome sequencing or whole exome sequencing, is done from the child's actual somatic cells, not from the stem cells harvested at birth. And there is a known estimated 2% rate of DNA error replication with each cell division, and these tend to accumulate. And in some cases, genetic typing from peripheral blood, which is mostly done on white cells, and the buccal mucosa, the epithelial cells show differences. So there is a different result from testing the two. Specifically, we had the situation of a boy with a GABR2 genetic defect, which is a serious condition explaining the ASD pathology and also seizures, who was refused by another center because of this genetic consideration, was refused for autologous cord blood administration. But we have accepted this SNP genetic issue, and we have administered the cord blood, and fortunately there were excellent results after that. The boy made clear progress on the areas of attention, interaction, behavior, recorded on video. Ideally in children with identified genetic issues on WGS or WES, which was done on blood, peripheral blood or buccal swab, we should also perform this test, the whole genome sequencing on WES, on the stem cells from the cord blood itself, considering that there may be important differences between the stem cells from birth and the somatic cells, the mature cells, which were isolated from the child at 2 or 3 or 7 years of age after multiple cell divisions.
Okay. How do you envision the future of the cord blood therapy in the ASD management?
Sure, it's a good final question. We have to say from the very beginning that the treatment we have studied in the CORDUS study, the autologous cord blood, is not standardized. And there are great variations both in the quantity, the number of TNCs and the hematopoietic stem cells, and the quality of cord blood. Some of them, as we mentioned, have embryonic-like stem cells, which is a totally different thing.
Okay.
And these differences are present, of course, between different families, but also different births in the same family. So this lack of standardization is something that we need to consider and study further. This variability represents a great challenge, which adds to the fact that ASD pathology itself is very different from child to child, as we said in the beginning. However, the autologous cord blood has the big advantage of minimal risk to the child, which is very important considering the unknowns and the very young age when it is administered, and the fact that ASD is a non-life-threatening condition. And having a minimal risk translates into a very favorable risk-benefit balance, which we need to consider for every patient. And makes it, the autologous cord blood administration makes it a direction worth exploring further, especially in the age interval where we have seen it working best, meaning children under the age of 7 years. For the future, we have two main directions for research, and one is finding new biomarkers which can help us better predict the children who are most likely to benefit from administration of cord blood, so we don't shoot in the dark. We know you have a much better chance of improving with a certain pathology and a certain blood product. And we are looking for these biomarkers both in the child, where we think that a high initial value of the neuron-specific enolase, NSE, and the inflammation marker such as TNF-alpha, taken together have a better predictive value for the usefulness of the treatment. They can predict the child who is more likely to benefit from cord blood. Also, we need to study in parallel the qualities of the cord blood, which is likely to make the treatment more effective. And so far we have looked, as we mentioned earlier, at the ratio between hematopoietic and mesenchymal stem cells, the CD133 for hematopoietic and CD271 positive, but also 34, 45, which was showed that determines the site of implantation, where in which organ the cells will go, the stem cells will go. But surely there are other important factors, and we intend to look into the presence of embryonic-like stem cells, those OCT4, SOX2, NANOG surface cell markers in the cord blood. And we think testing both the child's blood, peripheral blood, and the cord blood itself, and obtaining for both a microRNA profile will help us confirm those findings and make cord blood administration more precise. Finally, and importantly, because today only about 3 to 7% of families harvest cord blood at birth, I think it is worth encouraging the practice of harvesting cord blood. So the availability of the medicinal product itself is increased. And we can do this by both raising awareness among obstetrics staff on the value of cord blood, but also by mandating the parent to make an informed decision on the fate of perinatal tissues, cord blood, umbilical cord tissue, and placental blood and tissue. And the practical recommendation or practical consequence would be that at one of the prenatal visits, the parent should be informed on the possible importance of this resource, the perinatal tissues, for hematology, oncology, neurology, and regenerative medicine. And the parents have the time to consider all this information and sign an informed consent, which agrees to one of 3 possible scenarios. One is discarding one or all the perinatal tissues as medical waste. Another scenario is donating these tissues or part of them for use by other patients for treatment or for research purposes. And of course, another scenario is cryopreserving these tissues for possible use by family members, by the child or other family members.
Perfect. If I may say, I have also my own conclusion. I can see hard work for you, and for sure better or even brighter future for those kids that weren't so happy, let's say, or lucky, better say. Felician, thank you very much.
Thank you.
As always, a conversation with you is always extremely fruitful. I have to thank you on behalf of Biogenis and also on behalf of my colleagues from Famicor Group and Vita34 also. And I hope that we will have also other chances in order to discuss and for sure to learn from your vast experience. Thank you very much, Felician.
Thank you also.